Okay, there we are. So let's get started on July 26th, and it's 2023. My first apology is this. Dr. Hines and I and AHA had the wrong date in communication. So they have agreed for Heart Health Month, they will come back on February 28th, the fourth Wednesday in February. So we will still get to hear from them, but not today. So today, I'm going to provide you with an overview of the simple things around heart disease, collect any questions that you may have, and have an input. And I've got to, I know you might be a little disappointed, but we will move forward with happiness, joy, and a smile, right? Because we're going to learn something, because that's just the way life is. You make lemonade out of lemons. You don't frown about the rest of it. So, but we will have AHA come on in February. So with that being said, anybody want to share a positive thing from their day today before I get started?
I'm positive that it's very hot out here. It's 111 degrees today.
Oh, oh, wow. Well, we know where you are in Nevada, right?
Yeah, but I mean, that's not too bad because we've had worse.
Okay.
I think the worst we've had is 117.
Wow.
Yeah,
Where is
exactly.
that?
Wow. That's a big. That's Stephanie.
Where's that?
Talking in Vegas.
Yeah.
Ooh.
So it's so hot that when you walk out, you really got to take your time going across the parking lot, because my arms were burning and my shoes, I said, I think my shoes are melting just trying to get across the parking lot to get into the store.
Okay.
So
Wow.
you just have to take your time and just drink a lot of Gatorade and a lot of water.
Oh, got it. Woo. So I want to talk about today giving everybody a simple understanding of heart disease. But let's start with this thought. I want you to think about cancer, and I wanted you to think about heart disease. And what I'm going to tell you is that the risk of each are equal because of these three factors. Number one, I bet you can guess it.
Diet.
Smoking.
Smoking. Yeah.
The second thing, you said it, diet. And then the third thing,
genetic.
That's a good guess. But the third thing that's really in common, there's a group of women that meet Monday, Wednesday, and Friday, and they
Exercise.
There you go. And it's the lack of exercise.
Right.
So those are the three things. But I think we to level set and make this an interesting conversation and understanding why heart disease is so important is when you think about cancer and heart disease, that those three things have in common. If we work on those three things, we can reduce the risk in those areas for both. So today,
Lisa,
yes.
Did you say smoking was number one?
Yes. For
okay,
both.
Smoking, diet,
yes.
and lack. Okay,
and lack
thank you.
of exercise.
Okay.
So.
And the three things were heart disease, cancer, and what was the third one?
So no. It's heart disease and cancer are what we're talking about. And
Gotcha.
the three things that they have in common that basically make them equally make you at risk are those three things that we just stated. Okay. So what our discussion areas are for today, and I hope we get through it, and I will share this overview slide set with you afterwards. Japs, our event coordinator, is on, and she'll make sure you get a survey as well as get these slides and all of the resources. We're going to talk about underlying conditions. Somebody already said genetics, our lifestyle factors, healthcare factors, social determinants of health, and then talk about the types of heart disease that are common for African Americans and underrepresented populations, look at prevention and then management. It sounds like a lot, but it's less than 15 slides, okay? So here we'll get started. Understanding basically the diagnosis. When you think about heart disease, one of the most common is CAD, and that's coronary arterial disease is the most common. And the risk of death from heart disease will most likely affect older people. So when you think about that, but what is interesting is that risk with older folks, when you look at African Americans or Blacks, those younger under 50, we're twice as likely to die from heart disease than our white peers. So understanding this is very significant and important, okay? And ask a question at any time. So underlying conditions that are attributable or associated with it. So we have a higher rate as African Americans of having some of these underlying conditions that contribute to heart disease: high blood pressure, obesity, diabetes, lipid disorders, and sleep disorders. I draw your attention to the bottom: sleep disorders. If you don't get enough sleep, there's extra stress that's put on your body and your heart, your metabolism can go out of whack, etc. So there are a lot of different reasons to think about getting a good night's sleep. Think about the fact of, if you're going to exercise, don't exercise at night too late, because your body's revved up and you might not get a lot of sleep that way. Cut your TV off, just simple things. I think that's a very important and simple thing to address sleep disorders. The others, high blood pressure, obesity, diabetes, and lipid disorders, are hypocholesterolemia. When you think of lipid disorders, when you go and see your lab results and you see what is your HDL, your LDL, those things, we'll move on. But those are the underlying conditions that contribute to what we know as heart disease. And we have a higher risk for these. Okay. Now, genetics and lifestyle factors. So when you look at those, somebody said genetics and genes and cancer having that in common. There are certain genetic lipid disorders, I don't know the names of those, that are more common in African Americans. But that's something for you to be aware of and to know. We know that genetics plays a role in our risk of having high blood pressure. We understand that. And then there is the risk of inflammation, which leads to the plaques that are found in the arteries that clog those arteries. There can also be genetic defects that cause a different structure or function of our heart. Now, lifestyle factors, here we come from that lack of physical activity. Oops, I left the T off of that, forgive my typo. But lack of physical activity, diet, and smoking. Those are those three lifestyle factors, right, that we talked about at the beginning that are in common with cancer. So here we are, we're talking about underlying conditions, genetics, and lifestyle factors. The next area we want to talk about, we may spend a little bit more time, because these are areas in which we want to look at the community and things that are aligned sometimes with health with disparities. And those are healthcare factors and social determinants of health. So we often are faced with barriers within our community that keep us from getting the quality of care that we deserve. And this, we know, has been brought to our attention much more recently when we talk about health equity. We hear that all the time. Our access. Think about where some of us live and where we don't have good access to medical care. Look at the rural areas we may live in, or in the inner city. Think of Richmond. Just think of Richmond and think of Petersburg. Healthcare has improved for our community, but once upon a time, you couldn't find a hospital within those communities. You had to travel back to VCU or MCV, as it was called, to get that care. Those things are still happening throughout the country. The quality of care that you get can be questionable. And patient and clinician relationships. How we find a clinician speaking to us, understanding the culture, the barriers. You know, Dr. Winchell, Dr. Curry Winchell, when she was here, she was talking about some of those disparities and some of those areas and the difference in the way that we are treated, in the way that we may receive certain medications, et cetera. Adherence to medications. If you don't have someone in the house who can help you take oral medications, line it up. If you have a lot of medications to take, you may not take them. If you can't afford medications, you won't be able to take them. So those are healthcare factors that impede our access to care or the quality of healthcare that we may get. And not having that is one of the things that may lead to a higher risk of heart disease. If you can't get to the doctor, get a stress test, if you can't, all those things will lead to the problems that we may see. Another area that you hear or about most often are social determinants of health. These are non-medical factors that can determine health outcomes. So we always think of smoking, we think of someone who may have, let me think of something, high cholesterol, who may have may have diabetes, may have experienced a stroke or whatever. But what these are the things that have nothing related to medicine or health, that are related to our ability to manage those number one underlying conditions we were talking about. So think about your income. Think about having a job that you're able to keep consistently. Job stability is important. Where you live, we talked about over here under access. Available transportation, something that simple. People may not have a car, may not have a bus route, may not be able to afford an Uber, may not have someone, if they're a senior, may not have someone in their family who can come pick them up and take them to a physician or to the doctor. Those things are sad, that we can't find a way to get have those things for us. Our level of education sometimes impedes what we can have in terms of access to care. And then finally, the one that we tried that we often don't talk about, okay, I see in here, cultural beliefs to medical mistrust. All right, that's a good one. It leads to that for sure. But the other thing is systemic racism. And you can't avoid that. And those are the things that we are all trying to overcome and address. And those cultural beliefs to medical, is that, who wrote that one? MLM, want to comment? Cultural beliefs to medical mistrust.
I'm sorry, can you hear me, Lisa? Hey, everybody.
Yeah.
I always butt out, but at least Lisa's so great and she stir up such energy and spirit around such great information. I just had to chime in, but she's listing them all as beautiful. Among them is sometimes our cultural beliefs are a part of those SDOH she's talking about, those social determinants of health, because your culture, what you believe can impact how you perceive going out there to get care, how you perceive care. And so in some cases, you may have a healthy amount of medical mistrust, in which case this can impact your care. So I was just mentioning that also, but I'll butt out. Thank you. Sorry.
No. Everybody butts in. There's no butt in or butt out. It's sharing. This is conversation and discussion. So don't do that. Okay. All right.
Lisa, along
Yes.
those same lines that Mark had just made, I think that cultural differences can also apply to the doctor.
Yes.
Sometimes they think that some cultures have a higher tolerance for pain, and I could go on and on and on, but I've just seen that, and I've sat in on classes where they've talked about it.
You're absolutely right, Mary. And there are courses that now physicians are being provided on culturally sensitive ways to interact with patients that are being taught through diversity, equity, inclusion courses. They get more of that in medical school and in training because of exactly what you said. And there are those unconscious and conscious biases that when you see a patient, you just respond or react a certain way. I'll give you an example that was shared with me. One of my Hispanic colleagues had her father, who was a senior, went to his physician, and he had diabetes. And the physician's reaction to him was, "Oh, you just need to stop eating those corn tortillas, so many of them." Oh, wrong. He wasn't even one who ate like that. So that wasn't his problem. But to your point, those biases and being voiced by somebody is damning and harmful. So he was with his daughter, who was in the profession, found another physician because there was no reason to go back to a physician that you were uncomfortable with. And we've talked about it. It's your right to seek additional and other medical care. That's exactly your right. So even though some of these social determinants of health, like the education, are outlined, sometimes for African Americans, that last thing, even those with higher education may still have a higher risk and poorer outcomes. It's not always the case. So they're just outlining that for us. Okay, let's talk about, I went too fast, my little wheel. The types of heart disease that are common amongst our African Americans. We started out by talking about the coronary artery disease, arrhythmia, when your heartbeat either beats more quickly, more slowly, but it doesn't do it in the normal, regular pattern. Atherosclerosis. Atherosclerosis is the condition where your arteries are clogged either by calcification or by fat. So those are two examples of atherosclerosis. Cardiomyopathy, that means that there is pathology within your heart that is causing a problem, and as well as the problem with congenital heart disease. So at birth, you're born without a valve, or you have your patent ductus arteriosus, it doesn't close. Just all things that happen at birth that may have a problem, but that's more common for us. And the heart valve disorders. So within the chambers of the heart, you have the valves that let blood flow forward and keeps it from going back. If you've got a problem with the way it flows, with the blood valves opening and closing, that causes a problem with the way your heart will stabilize itself to pump the blood in and out. You can overfill or you can not fill enough. Peripheral arterial disease, PAD, that's when you look at your body and there is problem with your oxygenation in those areas. It's a very painful occurrence that can happen, but there are more of us African Americans who have that condition. And with PAD, there's often unfortunate outcomes of loss of limbs that can be seen with that. Questions?
Lisa, those are fantastic reminders of some of the conditions related to the heart that could actually be alarming. And among those, among that conversation is the idea that once you decide that you really want to be serious about your heart health and your health, it's important to talk to your doctor and know, because as Lisa was mentioning, some of those things can be things that either you were born with. There can be things that you are not aware are your condition. You literally can have a blockage in your heart that you're unaware because it may be asymptomatic or you may not feel any pain or discomfort. So it is important to, once you make that determination, to say, you know, I'm going to turn it up a bit and I'm going to do better by myself, to talk with your doctor and make sure you have a good heart baseline so you can be aware of maybe some things you did not know.
Good point, Mark. And Japs, thanks for sharing that you were diagnosed in 2008 with mitral valve prolapse. You're talking about irregular valves and the way blood flows in and out, and that flows in and out through those valves.
Yes.
And it led to her arrhythmia. Do you mind, Japs, sharing what some of your symptoms were or some of the things that caused you to go and seek help?
I had a hard time breathing. It felt like I'm always catching for breath, and I could feel my heart like pumping. Sometimes I could feel my heart pumping out of my chest.
Ooh.
And I was diagnosed when I was pregnant with my first child.
Okay.
And so I was not allowed to like do cardio exercises, not much, just regular walking for now, because if I run and do a lot of cardio, I couldn't breathe. I'd to the extent I'd pass out. Then I have a lot of palpitations. Even up to now, I still have palpitations, but because I'm used to it. That's what the my heart doctor said, that you get used to it, that sometimes it's still there, but to the extent you don't feel it anymore.
And how did they treat it, Japs?
The arrhythmia, sometimes they kept monitoring me there's a device hooked up to me that I know, it's like EKG, and I went through different heart what do you call this, lab work for the heart, and eating healthy, drink a lot of water, and I need to do more walking, exercise, stretching. So they're not trying to limit me with the exercise, but try to choose the right exercise for me so that I won't suffer with catching breath, and to the extent that I will have to seek more medical attention.
I gotcha. Well, thank you for sharing that.
Thank you.
Yeah, that's one of those valve related issues. That's a better way for me to say that. And it talks about the arrhythmia that can be caused with that. So the next thing we're going to move to, does anybody have any questions at this point? So this is what we all want to think about, right? We want to think about ways in which even now we can look at prevention and what we can do to be healthy. First and foremost, understand your risk and your family history. Sometimes that's a problem because we don't all know our family history. We need to learn. Here's an opportunity. We need to share with our children, our grandchildren, and we hope that our parents, uncles, aunts, when we're talking, share their health conditions. Don't just keep them quiet, because it's only going to help us the more we know about our own health story and journey. It's important to know if a parent has diabetes, if somebody's been on cholesterol medication, if someone has high blood pressure, et cetera, or even had congenital heart disease. So talk to family members and find more about that. Also, screening is a mainstay. Screening is done. When I say this, please plan for your annual physicals, and in that, ensure that you are getting regular lipid panels, your blood sugar is monitored, and you get now what we know as the coronary artery calcification test. If that's not something that a physician is talking with you about, that's something that you should mention and say, hey, tell me more about this. What does that mean? Belinda, I see your hand is up.
Yes, I just wanted to comment on the one in the point that you made about knowing your family history.
Mhm.
I understand the need for that, but sometimes when you go to the doctor, it works against you, because rather than run tests that are applicable to the reason that you're there, they start asking the family history, and then they make decisions based on your family history without having done a full workup to know what your problem might be. So sometimes it works against us because, well, your family history is such and such and such, so you're more likely to have A, B, C, and D. And I've heard that before, and that has caused me to change doctors because of that.
And I like what you said. You said they don't run the rest of the panel and don't do that. So instead of it working against us, it should be additive. So that if someone stops doing the tests that are necessary so that all options can be open to us, you're right. You need to make a switch or make a change. Family history and panels and the screening are additive. This didn't say one or the other. It's doing and using all of them. But thank you for bringing it to everyone's attention so that if we hear a physician taking us down a certain path, we know that we need that path not to be so narrow, but to be more broadly opened for us. That's what these conversations are for, to empower you to say, wait a minute, isn't there something else we can do or something else you can consider? And gently push back. That's what we want to do. Japs, you just provided us with some warning signs and symptoms related to the mitral valve prolapse and the arrhythmia. So the chest pain, don't ignore it. Fatigue, don't ignore it. Shortness of breath, fast or irregular heartbeats, pain and swelling on your leg. That's that peripheral arterial disease we were talking about. I'll give you Cedric's example, and I'm sure he will not mind. And those of you who know my husband know he's tall, slender, fit, and in good condition. But Cedric started experiencing difficulty going up and down steps. And so he's like, I can't do that, or whatever. Or he would, in certain normal situations, be out of breath. Well, when he went to, I was like, that's not normal. So when he went to his primary care physician, the primary care physician sent him to the cardiologist. And the cardiologist did an ultrasound, found him, and said, okay, it was an immediate notification that he needed to start on a statin get back to him and go in for a stent. So if anybody knows anything about heart disease, he had an occlusion, and he had an occlusion on the anterior ventricular, wait a minute, which one? Well, I'll just call it the Widowmaker. So if he had not gone ventricular, yeah, the anterior ventricular artery, and that one going in saved his life. And so just being aware of that change in him, just walking up and down the steps and being short of breath was enough for him to make a change and to see a difference. So that's an example. Stay active. I love this one. I think that every St. Peter woman who's a part of the exercise group can get 5,000 stars, because you all do that Monday, Wednesday, and Friday, and you have your exercise class for an hour during that time. Kudos and hats off for what you do, and have that support system in place to do that together. That's great. Manage your weight and your diet. It's important for us to know whether you're diabetic, you have high blood pressure, or you have cholesterol issues, or you don't have any of those, to understand that when you reach a certain age, your metabolism and body changes, and how you eat and what you eat will make a huge difference. If you are looking to manage your weight, gain, lose, or maintain, reach out to your registered dietitian and seek that counsel and that support to help you with that. It's not an easy task once you reach a certain age, and as females, we know that. For men, it seems like it takes a little longer to catch up, but those are some things to do. And by all means, when we looked at the other area, take your medication. You know, if you have been prescribed medication and it's not causing you harm, or you don't feel like you're unable to tolerate it, continue to take it. But if you don't feel like you can tolerate it, speak up and go back so that you can be evaluated and see if there's another medication that might be better for you. I'll pause there around prevention. This is really important for us. Oh, okay. And then
Lisa, I'm gonna, you open the door. I want to say something about that. You're right. I would love to have everybody, even if they don't chime up, to think to themselves, how often do we talk about it in our community? And I think even though it's almost taboo that we disclose personal health information in our community, if we start to talk about those things that we're comfortable, then we can be examples to the rest of our community, so people can start to understand that we can share information based on even the questions you all ask, the fact that you are here, the fact that I've seen many of your faces on a number of these very valuable meetings, tell me that you yourself, even if you're not a health professional, that you have a great deal of awareness about things, and talking among your family members and sharing what you know with people around you is very, very important, so that we can begin to try to get our community to realize that we need to talk to each other, share this information so that we can stand in the gap for each other. But there we go.
That's right. That's why we've come together, because many of us have come to each other and asked each other these questions, and we want to continue to talk about it and have the support that we need and empowerment that we're looking. So the management of heart disease, we just talked about at the end, take your medications. And if you have some form of heart disease, that's okay. I mean, it's not the end of the world. We can live with heart disease. It's manageable. And our treatment of whatever it is, you saw the different types. There are different ways that that's going to be managed and treated. The most important takeaway from Dr. CW, Dr. Cherry Winchill, was know your options. You remember that conversation? Know that there are many options for the way congestive heart failure may be treated, high blood pressure may be treated. And just because you are African American and they say that a statin should be given, there's new information about statins. It used to be you do a statin, but now, and they used to say, don't worry about your lipid panels, but now that's different. You should worry about your lipids. And it's not just a good thing to have the good ones. You need to watch all of them and know that about what's taking. We need to be willing to understand and know earlier research and what we can participate in clinical trials. And there needs to be new research, which in that new research, we need to be included in that research. So today, our call to action is, you already saw it, those 3 factors that show that heart disease and cancer are basically the same. What we need to do is recognize that while there have been significant improvements in heart disease, currently Blacks are not experiencing the same benefit of those outcomes at this point. So we need to take advantage of those ways to prevent it and understand it. Giving the disparities that we have seen, we have an opportunity in which we need to manage and control better our blood pressure, our diabetes, and our weight. So I want you all to think about the ways that you all can prevent heart disease and manage it with your health, and share that with others within the community. That's all I've got today. I'm open to questions, and thank you.
Lisa, I have one.
Okay, I'm going to stop sharing so I can see everyone's beautiful face. There we go.
Lisa,
Yes.
when you go to your primary and they do your blood work, well, we know we're working with diabetes, cholesterol, and blood pressure. Are there other blood tests that we need to be looking at along with those 3? How many tubes of blood should they draw? Those 3 plus, or just those because that's what they know you have? Are they looking for anything?
Stephanie, my nurse on the call, can you answer what's the normal tubes of blood that someone takes at a physical? I know I usually get 2 or 3 vials.
Yeah, it's usually 2 to 3, and really they can do everything they need to with that. Because I always get them to check my A1C, for the diabetes, because that runs in my family. I also have them to check my potassium, magnesium, because all of that affects your heart. And I get them to check my vitamin D, because women tend to be low in vitamin D. And with me being a night nurse, I'm not a night nurse anymore, but when I was a night nurse, I went and got all of that checked, and my vitamin D was so low that it was ridiculous. I was taking 50,000 units of vitamin D, so I had to take 1 pill a week because my vitamin D was so low. So when they take those 2 to 3 vials, they can really run everything, and just, you want a complete blood panel. So there's a CBC. So when they do that, they can give you everything that you want and don't want. So that's usually what I do once a year. I tell them I want a complete workup, and I get everything.
Okay. Thank you.
You're welcome.
Hey, Lisa, this is Teresa.
Hey, Teresa.
Hi. I wanted to ask Stephanie if that should also include inflammation markers when you're thinking about heart disease. Is that important?
It absolutely is important. I'm just trying to think. Yeah, so when they do, I always tell people, please, ask questions. You know, if you feel like they're rushing you along, then you need to find somebody else, because doctors and all need to take the time to listen, to the patients and all. And it sounds like most of you guys are doing that. So good job to that.
Yeah.
But yeah, those should show, your information markers and all that. So like I was saying, your potassium and your magnesium and your sodium, all of those are on there as well. All three of those are important. Magnesium and potassium, those affect your heart. The sodium, if your sodium is too low, you can have seizures. So all of those are listed on your complete workup, and so that will actually help, with your heart markers and all of that. Your troponin and all of that should be on there.
Yeah, so when I think
Okay.
of what you just asked, Teresa, I think about the sedimentation rate, the ESR,
Mm-hmm.
that's on there as a blood marker, and they
Yep.
use plasma viscosity, and there's one other I'm not thinking of. It might be the CPR or the erythrocyte marker. And I know that sometimes the sedimentation rates can be elevated in Black people.
Yep.
Yeah.
And so because of that, we need to know that so that we understand that risk. We wouldn't know that except we're having this conversation. So you ask somebody, or you come back and say, hey, these are my lab results. This is what my doctor said. And having a trusted nurse practitioner, or somebody that you can really talk to about that. And they do have on blood lab reports now Black and white ranges, and paying attention to that is key. Usually, Gwen, to how long should a blood test result? It doesn't take long at all. 48, 72 hours. I often will go the morning of the day before my appointment for my annual, and they'll have my results. Might be that the doctor hasn't read them.
Right.
They might be in the file, but they usually have those results. So, Teresa,
generally
I always
taking
like a
about
nurse.
20
Say it again, Gwen. Sorry.
Mine are generally taking about 20 to 25 days to get results.
What?
Oh, no,
What?
if you have my chart, I'll give you an example. When I was in the
Yes.
hospital, they would take my test. I had my smartphone within hours, not hours, but almost minutes from the time they took it until I could pull it up on my chart before the doctor even saw them, but definitely
Yep.
not an hour.
Yeah.
I have my chart and all that, but an example, I saw my doctor or did the lab work July the 7th, and I am still waiting for the results.
That's ridiculous. That is ridiculous. You should have had your results by now.
Exactly.
Yeah, and yeah, there needs to be a reason. They need to change that. And the opposite can happen. Sometimes you can get your results and they pop up before you have a chance to get to the doctor, and you're shocked as to what that means and how you got it. But wow. Call me offline, Gwen. I may have a suggestion for you. Okay.
Okay, great.
All right. But good question. Anybody else? If I will make if you're interested, I will send out to those on the call these slides. We can also post them on BAAHRI, and we'll share that. We're going to ask, if you don't mind, take a survey for us. We have upcoming programs for September, October, and November. September, we're going to discuss liver disease. October, we're going to discuss breast cancer and family caregivers. We've got a survivor, Betty Jackson. No, is it Betty Japs? Get me right. But Miss Jackson from the Sisters Network will come and join us with her story and talk about the Sisters Network. And then in December, we have another treat. Stairwell Chronicles, Dr. Jane Middlebrooks who talks about COVID in her stairwell chronicles, is coming so that we can understand more about immunization and COVID as we hit these winter months. So that's the end of our 2023 programming. And then we'll begin with 2024, knowing that in February, we'll have heart health with the AHA. Please complete the survey so we can capture the topics that you are most interested in. If there are repeats that you'd like to have, we'd like to do that. We extend invitations to all of your friends and those who can join us. We love your being here. It's intimate. It's nice. The right people come to these calls. We hope they're benefiting you. And August is a break. Vacation and rest is important. So we'll see you in September. If you have more questions, I'll stay on the line, but thank you so much for joining us. And I hope that you will have a heart healthy evening.
Hey, Lisa,
Yes.
I wanted to say one quick thing. Telling y'all about vitamin D. This is how you know when your vitamin D is low. You're super tired. You just have no energy and you're just kind of like dragging along. And if not getting enough sun, then of course, all that could happen. And I can't go out in the sun right now because I would just pass out because it's just too hot. So those are some ways to know that when your vitamin D is really low, you're dragging. You know how you feel normally. So if you're feeling like you're dragging a little bit more than what you should, make sure you just tell the doctor, just check my vitamin D to make sure that I'm okay and I got enough in me, because you need to have that.
Right. And I
That's
think
it.
another thing too is aches and pains, unexplained like aches and pains. You might have
Yeah.
joint aches,
Yep.
muscle aches. That
Yep.
also might be an indication.
Yep.
Teresa, before we end, do you mind sharing putting in the chat your podcast?
Oh, Lisa, thank you. It's called Earrings Off. That's my picture. That's the logo right there.
Yeah.
Earrings Off. I'll put it in the chat.
Yeah. So Teresa is great with nutrition and homeopathic understanding. She's a great person to have on this call and was able to join us. I think in 2024, we may ask you, Teresa, to join us and talk about some things. I think it's significant and important for that. And just put the information in the chat. Japs, you grab it from the chat and send it out in our follow-up, if you don't mind.
Yes.
Okay. So we appreciate each of you. Like I said, I'm going to end the recording now.